This conference will now be recorded.
Any complaint pertaining to the anal canal, anal region, every patient will come that, sir, నాకు piles ఉన్నాయి sir, నాకు ఇట్లా ఉంది sir, ముడ్లో piles ఉన్నాయి ఇది. So these are the common complaints. So whether he doesn't know he is having fissure or a fistula or any other anal cancer or a rectal cancer or a prolapse of the rectum, but he will tell that any mass coming out is, he feels that it is a piles only. So that's why this topic is very important. And clinically also, in the daily clinical practice also, usually most of the patient come to this come to the surgical OPD with this complaint. Okay, this is an important topic, and it is an important topic for examination also. Okay, so now we will go into the topic proper. So as I have said, any question given you have to write in an orderly fashion. So we will be discussing, I will be telling this topic under the following side headings. So the definition of hemorrhoids, what are the types of hemorrhoids, what is the etiology behind the occurrence of hemorrhoids, what are the clinical features associated with hemorrhoids, what are the complications of hemorrhoids if not treated, and how do you manage a case of hemorrhoids, both non-operatively and operatively. Okay, and what are the post-operative complications. So under these side headings I will be teaching you about this topic. Okay, so coming to the first definition of hemorrhoids. Okay, so here you should be knowing that, see, if a group of people, see, some if you take some 50 people, and you do a proctoscopic examination in the surgical OPD and you put a proctoscope inside, definitely you will see bulgings inside the anal canal. Those are nothing but the anal cushions. I have told you in the surgical anatomy of the anal canal, those are the anal cushions. Anal cushions are located at the three positions, that is the primary positions, that is the 3 o'clock, 7 o'clock and 11 o'clock. Here you can see in the right lower corner of this slide, there is a picture depicted when the patient is in lithotomy position. So anteriorly it is the perineum, here it will be the coccyx. So if you think that this is an anus, okay, this is an anus, if you think it as a clock or as a wall clock, you can name it as, this is the 3 o'clock position, this is 9 o'clock, 12 o'clock and 6 o'clock. So the primary position of the anal cushions are 3 o'clock, 7 o'clock and 11 o'clock. That is the left lateral, right anterolateral, right posterolateral. Okay, so anal cushions are nothing but there are the superior hemorrhoidal plexus. These are nothing but the superior hemorrhoidal plexus which are located in the submucosa of the anal canal. Okay, whenever they get bulged or when they were rupture and they cause bleeding, then only you should be calling that they are having hemorrhoids. So in every patient, if you see, even if I or you, any patient, if you go and undergo a proctoscopic examination, definitely you will have anal cushions. Every individual will have anal cushions, but those are not called hemorrhoids. Okay, those are termed as hemorrhoids when these anal cushions bleed. So the definition here comes as symptomatic anal cushions. See, I have written symptomatic anal cushions, not just anal cushions. Symptomatic anal cushions, that is the anal cushions which protrude out, or the anal cushions which are located within the anal canal but they bleed. So symptom, bleeding is a symptom. So these are the symptomatic anal cushions which are located at the 3 o'clock, 7 o'clock and 11 o'clock position. So when the patient is placed in the lithotomy position, so here you can see in the diagram, the patient is in the lithotomy position. You can see the both buttocks, anterior perineum, behind posterior is the coccyx, middle is the anus. So when the patient is kept in the lithotomy position, if there are symptomatic anal cushions at 3 o'clock, 7 o'clock and 11 o'clock, which are the primary positions, then they are called hemorrhoids, and those are internal hemorrhoids because they are located within the anal canal, inside the lumina of the anal canal. Okay, and they are located above the dentate line. Okay, if you just memorize the surgical anatomy of the anal canal, I have told you before. So usually these are located above the pedicles, are located above the dentate line. Okay, so this is the definition of the internal hemorrhoid. So hemorrhoids can be divided, classified into, or types of hemorrhoids are three types. Those are the internal hemorrhoids, external hemorrhoids, and secondary hemorrhoids. So what this definition implies is internal hemorrhoids, and that too in the primary position. Then what are secondary hemorrhoids? Secondary hemorrhoids are those which are located apart from the primary position. So if they are located in between the 12 and 3, those it is a secondary hemorrhoid. If it is located between 3 and 6, it is a secondary hemorrhoid. If it is located between 7 and 9 at a 9 o'clock position, it is a secondary hemorrhoid. Okay, those are the secondary hemorrhoids, and secondary hemorrhoids have a specific cause. Secondary hemorrhoids to occur have a specific cause. I will I will tell you about it later, okay, in the coming slide. So these are the types of the hemorrhoids. So here it is a picture. You can see here, you can see this. See, this is the internal hemorrhoid. I have told you this is the dentate line, the curvy line, the dentate line. Okay, so above this dentate line will be the internal hemorrhoids. Okay, that is the superior hemorrhoidal plexus of veins will be situated above here. Here you can see the external hemorrhoids. That is below the dentate line. This is the anal canal margin. Sorry, anal margin, anus margin, anal verge. Okay, at this level, in the skin, below the skin, in the subcutaneous tissue, there will be inferior hemorrhoidal plexus of veins. There will be inferior hemorrhoidal plexus of veins, which when gets dilated, then they are called as external hemorrhoids. These are located actually circumferentially, okay, all around the anal verge, okay, anal margin. They are located circumferentially. So this is the proctoscopic view. The right side of the right side picture show you a proctoscopic view. You can see the bulgings, bluish color bulgings you can see. Okay, these are the internal hemorrhoids. Okay, so what are external hemorrhoids? Okay, external hemorrhoids, I have told you, these are the inferior hemorrhoidal plexus of veins located beneath the skin circumferentially at the anal verge. I have shown you in the diagram. So these are the inferior hemorrhoidal plexus of veins. See here, you can see the veins on the right side. Here left side there is a swelling, that is an external hemorrhoid. Internal inferior hemorrhoidal plexus of veins situated below the skin in the subcutaneous tissue at the level of the anal margin circumferentially all around. Okay, those are external hemorrhoids. Okay, then these are sometimes due to outward. So sometimes these external piles may be associated with internal piles. These are associated with internal piles also. That is, the internal piles will protrude downwards. Okay, will protrude downwards, and along with this internal piles, these external piles also will bulge. Okay, there will be connection between the internal and external. So sometimes these are the outward extensions of the internal piles also. Okay, so whenever an external pile is whenever there is an external pile is seen, how it will appear? It will appear as a solitary single blue color olive shaped subcutaneous swelling at the anal margin. Here you can see, you can see this, it is an olive shaped. Okay, it is usually here there are two, actually there are two are there. Here you can see this is the anus, above is the anterior, below is the posterior. These are the buttocks. So here this is the anal opening, anal verge. You can see at the anal verge. So these are covered with skin. So difference between the internal hemorrhoids and external hemorrhoids is internal hemorrhoids are covered by mucosa because they are coming from inside to outside. Okay, they are coming from inside, so they will be covered with the mucosa. Okay, whereas external hemorrhoids, as I have depicted in the picture, these are covered by the skin. So that is the main differentiation between internal and, how do you say it is an internal and external hemorrhoid? Is internal hemorrhoid, as external hemorrhoids are covered by skin. So usually it will be a solitary. See, you can see bluish color olive shaped situated below the skin, okay, in the subcutaneous tissue, and they present as solitary painful thrombus. solitary painful thrombus. So what happens, so whenever there is a, why external hemorrhoids occur means, suddenly if the patient coughs, if the patient cough or strains while passing, while at the time of defecation, while straining for stool, when he want to pass stool, when he strain for passing hard stool, or when he lift a heavy weight, what happens, there are small vessels, small inferior hemorrhoidal plexus of veins which will be situated at the anal margin, which will break due to the pressure coughing. Okay, so what happens, there will be blood collected below the skin, that blood will be getting loculated and it will form a clot, thrombus. So what happens, due to the stretch of the due to the expanding thrombus, the skin will also be stretched over it. So when the skin stretches, there will be fine nerve endings at the over the skin. So when the skin is stretched, patient will have lot of pain. So these are the, this is the patient who will come very quickly to your surgical OPD, because patient will have immediate swelling will be there, painful, it will be painful. Okay, so they usually, external hemorrhoids will present as a painful solitary thrombus, and it is also known as 5-day painful self-curing lesion. 5-day, why it is called 5-day painful self-curing lesion is, it will be cured spontaneously. If you don't give treatment also, it will get resolved spontaneously. So this term is given by Mr. Milligan. Okay, Milligan has given this term as 5-day painful self-curing lesion. Okay, so how do you treat? When the patient comes within 24 to 48 hours, patient will give a history of that. Suddenly I have strained for a stool, sir. గట్టిగా ముక్కాల్సి వచ్చింది మోషన్కి వెళ్ళినప్పుడు, సడన్ గా ఇట్లాగా వాప్ లాగా వచ్చింది మోషన్ దగ్గర అని చెప్తాడు. వచ్చినప్పుడు సడన్ గా ఇఫ్ యూ ఎగ్జామిన్, యూ విల్ సీ దిస్ ఫైండింగ్. So what you can do is, you can take to the operation theater, or you can say take the patient to a minor OT. You instill a local anesthetic under the swelling, and you just give a nick, over the skin, and you will evacuate the clot, and the patient will have a spontaneous relief of pain. Okay, patient will have spontaneous relief of pain after removing the clot. Okay, that should be done when the patient comes within 48 hours, because the clot will be very soft. After 48 hours, what happens means, the clot will be the thrombus, where the clot, the swelling will become hard, and it is difficult to remove under local anesthesia. So what are the fate of this external hemorrhoid if it is not removed within 48 hours? What happens means, it may rupture by itself, and it will bleed and remove the spontaneously rupture, and the clot will be extruded out by itself. Number one. Number two is, it may undergo fibrosis and become a thick swelling. It will undergo fibrosis and it become a hard swelling. Okay, that if you want to remove, you cannot remove by local anesthesia. You should go to the OT theater under spinal or general anesthesia. You have to cauterize it, or you have to excise it. So that is one thing, fibrosis, rupture, or it will resolve by itself. It will resolve, the clot will get absorbed within the blood vessel, it will be resolved by itself and become soft. Okay, that is one thing. And another thing is, it will separate. Sometimes long standing clot, if the patient is somewhere diabetic, if the patient is having clot and it has been not been removed, it may undergo sepsis, undergo abscess separate, and it will form a ruptured abscess. Okay, so if not treated properly within 48 hours, it may rupture, or it may resolve, or it may undergo fibrosis, or it may form an abscess. Okay, this is the fate of a solitary external thrombus. Okay, this is the external hemorrhoid. So this is the picture. Okay, so what are secondary hemorrhoids? I have told you in the previous slide, secondary hemorrhoids are those hemorrhoids or anal cushions which are located between the 3 o'clock, 7 o'clock and 11 o'clock positions. Okay, so there are some specific causes for secondary hemorrhoids. Okay, when do you suspect secondary hemorrhoids are there? See, here are the causes, specific causes will be there. Number one is the local causes involving the anus and the rectum. Number two is the pelvic causes. Number three is abdominal causes. Number four is neurological causes. So for number one is local causes. So any carcinoma of rectum, anorectum, anorectal deformity, hypotonic anal sphincter. So whenever you see a patient, you have examined under left lateral position or a lithotomy position or prone jackknife position. These are the positions you usually examine the anal canal and the rectum. Lithotomy position, left lateral position or prone jackknife position. And if you see secondary hemorrhoids, apart from the 3 o'clock, 7 o'clock, 11 o'clock, you don't have a classical. Other than 3 o'clock and 7 o'clock and 11 o'clock, if you see hemorrhoids, you should look for number one, is there any associated carcinoma of anus or the rectum by putting finger inside? Okay, and you should see if there is an anorectal deformity. And you should see when you put a finger, is there any way whether the anal canal is anal opening, anal canal is spatulous or not. So whenever there is an hypotonic anal sphincter also, secondary hemorrhoids may occur. So that you should look for. Next, another thing, okay, that is ruled out. Local causes, no local causes, everything is normal. Then you should go for pelvic causes. So whether the patient is pregnant or not, gravid uterus, patient is pregnant or not. You should look for the study of whole of the uterus and the ovaries for any fibroid uterus, any ovarian neoplasm, or any carcinoma of the uterus, or any carcinoma of the cervix. This should be ruled out. And next is the bladder carcinoma. If any bladder carcinoma, that also the thorough investigation should be done and to rule out bladder carcinoma. These are the pelvic causes of secondary hemorrhoids. So, okay, pelvic causes also, there are no pelvic causes. Then you should look for abdomen. Is there any ascites of the abdomen? Okay, is there an ascites fluid within the intraperitoneal cavity, abdomen? Next, other is the neurological causes. Patient is having any paraplegia, is he having any cardiovascular accident or a spine injury where the patient went into paraplegia and multiple sclerosis. Okay, these are the usual causes, local, pelvic, abdominal, neurological causes which result in the occurrence of the secondary hemorrhoids. Okay. So now coming to the primary internal hemorrhoids. So these are all, now I have discussed all about the external and secondary hemorrhoids. Now we'll go into the proper primary internal hemorrhoids. Why? The primary hemorrhoids, that is 3 o'clock, 7 o'clock, 11 o'clock position, hemorrhoids are occurring. There are actually various theories are there. Various theories in the past are there which they have given the causes for the hemorrhoids. But the current concept is, now the current concept is, there are the shearing forces acting on the anus, shearing forces acting on the anus, which causes caudal displacement of anal cushions. Shearing forces means, see, when the patient strain for defecation, when the patient strain for defecation, there will be a forces acting at the anal canal. Okay, okay, acting at the anal canal. So what happens when the patient strains or when there is an intra-abdominal pressure? So what happens? There will be displacement, caudal displacement of the anal cushions. In the normal individuals also, when the patient strain, the anal cushions will come out. Again, they will retract back. After the passage of stool, the anal cushions again will go enter into the anal canal. But on repeated attempts, that is, patient is having repeated constipation, what happens? These anal cushions will be undergoing, still caudal displacement will occur, they will not retract, because so there will be fragmentation of the supporting structure. The supporting structures for these anal cushions, these supporting structures contain collagen. Okay, these supporting structures contain collagen. So this collagen will become disorganized and fragmented. So when this collagen becomes fragmented, the support will be also lost. So whatever the anal cushions which have been caudally displaced, which have come out due to the loss of elasticity, what happens? They will be protruding outside only. They will not retract back again into the anal canal. Okay. So once they are protruding outside, there will be mucosal trauma. See, these plexus of veins, superior hemorrhoidal plexus of vein, anal cushions are covered by mucosa. If that mucosa is prone to trauma, that will lead to bleeding. Okay, this is the current concept what they are saying. Okay, so but there are other theories that you have to remember, but these are not important, but you should remember and you should be writing in the examination also. Okay, but the current concept, that should be the first point. Okay. So other theories is in portal hypertension. See what happens in portal hypertension. There will be increase in the portal venous pressure. There will be increase in the portal venous pressure, loss of valves. Usually the portal vein have no valves, no valves. So what happens whenever there is an increase in the portal pressure, there will be varices. So superior mesenteric, inferior mesenteric arteries gives the continue as the superior hemorrhoidal plexus. So whenever the portal pressure increases, this pressure will be transmitted to the inferior mesenteric and it will lead to varices. But in portal hypertension, there will be rectal varices, not anal canal varices. There will be rectal varices, and you should not be confused with that of the rectal varices. You should differentiate whether it is an anal canal varices is a true hemorrhoids or there are rectal varices. If you operate this patient, if you think that those are hemorrhoids, primary internal hemorrhoids, and if you operate in a case of portal hypertension, patient will have torrential bleeding. Patient will go into shock and will finally go into death. So that portal hypertension you should rule out. Okay, number one. Number two is vascular causes. Some say that these hemorrhoids are nothing but the hemangiomatous structures. Hemangiomatous swellings. This occurs due to the loss of the erectile tissue, in the anal canal. Okay, those are called as corpus cavernosum recti. The loss of elastic tissue result in corpus cavernosum recti. Okay, that is another theory. Third theory is infection. So whenever a patient strains for passing stool, what happens? There will be due to hard feces, it will cause trauma in the anal canal. It causes fissure. So when there is a fissure in the anal canal, underlying the fissure there will be, below the mucosa and mucosa there will be submucosa, and there will be vessels will be there. So that vessels will be exposed to erosion. That vessels will be exposed to erosion and it will bleed. So that is one cause. But anal canal, there is another controversial statement that anal canal is very resistant to infection. See, whenever you do a surgery in anal canal, it will heal, though it is a high amount of bacterial flora there in the anal canal. It will heal. That is the nature of the anal canal. Okay, that will heal, though if there is a cut or if there is a surgery done for anal canal also. So that is also one theory, infectious theory. Next is the diet. If the patient take fiber deficient diet, if we take more of amount of protein, non-vegetarian diet, masala, fried rice, biryani, palav, noodles, kurkure, chips, ఇలాంటివన్నీ తీసుకుంటే మోషన్ will become tight, constipation will come. Okay, constipation will come. Okay, so the diet is very important. If he or she doesn't take fruits, inadequate intake of water or inadequate intake of green leafy vegetables, then the stool will become very hard. Okay, the stool will become very hard and the patient strain for stool. So when the hard feces within the anal canal causes obstruction to the underlying superior hemorrhoidal anal cushions, okay, superior hemorrhoidal plexus of veins, it causes pressure over that. So what happens? There will be decreased venous return. When there is decreased venous return, these will bulge. These will be anal cushions will bulge and later on they will bleed. Okay, next another theory is aging. So aging, what happens due to aging? Due to old age, what happens? The supporting structures, I have told you, the supporting structures for the anal cushion, they contain collagen. The collagen will be fragmented and disorganized in case of aged people. So what happens? There are more prone for uh, prolapse of the anal cushions and thereby bleeding. Okay, so aging. Next is another theory is anal hypertonia. See, anal hypertonia, there is they say that in patulous anal canal, though anal sphincter is hypotonic, also patient may get hemorrhoids, and hypertonic also there may occur hemorrhoids. Okay, so these are all theories are just for theoretical purpose, but the current concept you should remember that there are shearing forces acting on the anus that cause caudal displacement of the anal cushions. Okay, thereby mucosal trauma. So what are the clinical features? The clinical features of hemorrhoids are patient will present to the OPD with, sir, there is నొప్పి లేకుండా నొప్పి లేదు సార్, కానీ మోషన్కి వెళ్ళినప్పుడు కానీ ఇలా ముక్కినప్పుడు బ్లడ్ పడిపోతుంది అని, దారలా పడిపోతుంది, రక్తం పడిపోతుంది. ఇట్ ఈస్ యాక్చువల్లీ described as splash of blood on the lavatory pan, splash of blood over the lavatory pan. సో దారలా పడిపోతుంది, నొప్పి ఏమి ఉండట్లేదు అని అంటాడు. దట్ ఈస్ ది క్యారెక్టరిస్టిక్ symptom the patient present to the surgical OPD with the piles. Okay, painless bright red bleeding. Okay, and patient complaints of while passing motion, sir, I can feel some lump coming or mass coming out per the anus. నాకు కొద్దిగా వాపులా తెలుస్తుందండి, వాపులాగా తగులుతుంది అని చెప్తాడు. దట్ ఈస్ prolapse of the anal cushions. నెక్స్ట్ పేషెంట్ విల్ ఇంకా కంప్లైంట్ మ్యూకస్ డిశ్చార్జ్. పేషెంట్ విల్ టెల్ నాకు కొంత జిగటగా అవుతుందండి, అక్కడ జిగట వల్ల కూడా నాకు దురద వస్తుందండి ఆ ఏరియాలో అని చెప్తాడు. దట్ ఈస్ మ్యూకస్ డిశ్చార్జ్. డ్యూ టు దట్ మ్యూకస్ డిశ్చార్జ్, because the prolapse will be there, so rectus will be exposed to the outside environment, so mucus will be discharging. That mucus discharge will irritate the skin and cause itching. Okay, that is the complaint the patient will tell. And another thing is patient will complains of pain. Why pain is? Usually I told you it is a painless hemorrhoids, but pain will occur because whenever there is a tight anal sphincter, whenever a tight anal sphincter is there, there will be protrusion of the anal cushions. Hemorrhoids will be there. Underneath that there will be tight anal sphincter which is pressing this, that is squeezing these anal cushions. When these are squeezed, what happens? There will be strangulation. So whenever there is strangulation, there will be thrombosis and patient will have pain. Okay, sometimes there will be anemia also. Anemia is a rare feature because till that time patient will not come to the hospital. Usually whenever there is a bleeding per rectum, usually patient will come, but some patient who neglect about their health, they will have anemia. Sometimes we see patient having a hemoglobin percentage of 4 or 5 who come with a hemorrhoids because they just neglect themselves. Okay, so that is a rare symptom, anemia. That is hemorrhoids causing lot of bleeding, also which results in anemia. Okay, so these are the clinical features. So on clinical examination you need to know what are the degree of hemorrhoids, what is the stage of the hemorrhoids, then only you can plan in whether patient goes for non-operative treatment or operative treatment. So on clinical examination you have to decide which degree the hemorrhoids are present. Is it the first degree, second degree, third degree or fourth degree? So first degree are usually, see, when you put a proctoscope inside the anal canal and the rectum, you can see only piles will be there and the patient will have a bleeding, that's all. There will be outside external, nothing will be there. Patient will complain of just bleeding, but when you put a proctoscope you will see only piles, they are not protruding outside. Whereas in second degree there will be piles which will protrude out of the anus and spontaneously retract. Patient will tell, సార్ మోషన్కి వెళ్ళినప్పుడు బయటికి ముద్దలా వస్తుందండి, మోషన్ అయిపోయిన తర్వాత మళ్ళీ లోపలికి వాటర్ అంతటా అవే లోపలికి వెళ్ళిపోతున్నాయండి అంటాడు. దట్ ఈస్ ది సెకండ్ డిగ్రీ ఆఫ్ పైల్స్. ఓకే, నెక్స్ట్ ద థర్డ్ డిగ్రీ ఆఫ్ పైల్స్ is the piles will come out and it will not go after the act of defecation and the patient has to push them inside the anal. He will push with the hand. Okay, patient will tell బయటకు వస్తున్నాయి లోపలికి వెళ్ళట్లేదండి, ఇలా నొక్కుంటే గానీ లోపలికి వెళ్ళట్లేదు అంటాడు. దట్ ఈస్ ద థర్డ్ డిగ్రీ ఆఫ్ పైల్స్. నెక్స్ట్ ఈస్ ద ఫోర్త్ డిగ్రీ ఆఫ్ పైల్స్ ఈస్ బయట ఉండిపోతాయి, అట్లాగా బయట అలాగా ముద్దలా ఉండిపోతాయి. దోస్ ఆర్ ద ప్రొలాప్స్డ్ పైల్స్ ఆర్ ద ఫైబ్రోజ్డ్ పైల్స్. ఓకే, దట్ ఈస్ ద ఫోర్త్ డిగ్రీ, దట్ యూ షుడ్ రిమెంబర్. So here you can see that the B diagram is the first degree. Okay, when you put a proctoscope there are only piles within the anal canal. C is that second degree, they will come out, but after defecation he will go, after act of straining it will obviously go inside. See, third D diagram is third degree, they have been prolapsed and if you push them with your hand it will go inside. The fourth degree you can see they have come out, they have strangulated and you can see the bluish color, that is the thrombus formation has also occurred. Thrombus has also occurred. So these are the strangulated piles. Okay, fourth degree piles. So what are the complications? If you leave the hemorrhoids, what happens? There will be undergo strangulation. There will undergo strangulation. So strangulation will form. What happens? There will be obstruction to the venous return above. So what happens? The venous, there will be stasis of the blood within the piles. So there will be formation of thrombus. So thrombosis later will form into an ulceration. If you keep it for a prolonged time, if the patient is not operated, it will form an ulceration. Later, due to impedance of the blood supply, arterial supply also will get impeded and it will form gangrene. Okay. And rarely it will, what happens is there will be portal pyemia. So infection, because see, I told you superior hemorrhoidal plexus is a extension of inferior mesenteric. So inferior mesentery is directly connected to portal circulation. So any infection here in the superior hemorrhoidal plexus, the infection pus cells will go into the portal circulation. Portal circulation will result in portal pyemia. Portal pyemia result in liver abscess. Okay, but this is very rare phenomenon. Okay, so last complication is fibrosis. It will undergo fibrosis by, so when it heals spontaneously, it will form a big mass, tight, firm, hard mass. So it will undergo fibrosis. Okay. So now how do you manage? So how do you manage this case? So there are some treatment, non-operative and operative treatments. Okay. So initially there are, depending upon the degree of the hemorrhoids, you will plan your management. So non-operative, operative. Okay. So first is non-operative. Every time when the patient come to OPD, so before you plan for surgery for a non-operative or operative, you should say that you should advise for the diet. See babu, nu tinali, em tinali, pachangane tinali, non-veg avoid cheyali, oil foods avoid cheyali, drink lot of adequate water. Adequate water should be taken, and you take lot of fruits, banana, fruits, apple, fruits, green leafy vegetables. Along with that, you will supportively you will put him stool softeners and stool bulking agents. Here now we have got cremafin syrup. That is, you may be knowing the commonest syrup there are, we are using is the cremafin syrup. So stool softener, it is a laxative. Okay, it is a laxative. And stool bulks, so we will give isfagul husk. Those are the powders we give. Powders to be mixed in water and to drink. It will improve the bulk of the stool. Okay, isfagul husk. Okay, in the name, trade names are crema diet, fiber diet. Okay, those are stool softeners and stool bulking agents. And you should give the, regarding dietary habits, you should advise the patient. Okay, so first degree hemorrhoids, you can tell that patients that you can change your lifestyle, dietary habits, and you can prescribe stool softeners and bulking agents. And you should rule out the specific causes I have told you before, the local, pelvic, abdominal, and the neurological causes. Whether they are not there or not, you should rule out. Okay, then now coming to that non-operative invasive procedures. There are two invasive procedures here I would like to tell. Number one is the injection sclerotherapy. And another thing is the Barron's banding. These are the two invasive procedures. Okay, so this injection sclerotherapy is developed by Mitchell. It is called Mitchell's injection sclerotherapy. Okay, here the indications are for the first degree and second degree piles which are not been relieved by the lifestyle modifications or dietary modifications. You have advised the patient dietary habits, modifications, and lifestyle modifications, stool softeners. If the patients are using all those and they are regularly following the advice, but still the patient is having some bleeding PR, then you should go for injection sclerotherapy. If the advice what you have given is failed, then you should go for injection sclerotherapy, Mitchell's injection sclerotherapy. What previously in the old time surgeons they use is the Gabriel syringe. Just you remember Gabriel, Gabriel, Gabriel syringe. Now there are disposable syringes are available. Now they are not using Gabriel syringe. Gabriel syringe, that syringe is made up of glass actually. Okay, which have two finger bows, and for pushing the plunger. Also there is a finger board to push it. Okay, it is actually given in Bailey now textbook. You can see the diagram. Okay, Gabriel syringe. Okay, so what do you now, how do you perform this technique? So what you do is you put the patient in the left lateral position or a jackknife position, and you put a anoscope or a proctoscope. In a syringe, 5 ml of syringe, you take 5% phenol, which is mixed with arachis oil or almond oil, and you, here you can see the diagram. See, the needle is injected into the, not into the, see, not into the pile mass, it is injected into the base of the pedicle. That is, you should remember, you should not inject into the pile mass. Okay, you should guide the needle and you should inject at the base of the pedicle. So at the base of the pedicle you give 5 ml, you give this sclerosant. So 3 o'clock, 7 o'clock, 11 o'clock, you inject it. Okay. So when you inject, what happens? What is the mechanism behind this? Is it will cause fibrosis. The sclerosant will cause fibrosis, and it causes obliteration of the venous channels. It will cause obliteration of the venous channels within the pile mass. Okay. And at 3 o'clock, 7 o'clock, and 11 o'clock, you give. And after 8 weeks, you will ask the patient to come to surgical OPD, and you will reassess again whether they have contracted or not. If they are not contracted, again you will give 5 ml in the base of the pedicle. And here while giving, there is a, you have to take some precaution. That is, you should not inject too deep. That is, if you inject correctly, you should give in the submucosal plane. You should not give too superficial or too deep. If you give in the superficial plane, that is in the mucosa, what happens? It will bulge. Okay, the mucosa overlying the needle will bulge. So if it bulges, what happens? It will rupture and it forms ulcer. Okay, it is of no use. You have to give directly in the vessels which are located in the submucous plane. Or if you give too deep, that is below it, what is there? Internal anal sphincter will be there. Kada ide kada ikkada internal, you can see internal anal sphincter. So you have to give here, somewhere here. If you give in the internal anal sphincter, what happens? There will be chance of pelvic sepsis. There will be chance of pelvic sepsis. In case of male, it will spread and cause prostatitis. It will may cause prostatitis. Sometimes in females it causes rectovaginal fistula. Rectovaginal fistula. Okay, and in males it causes impotence. Impotence also may cause. So these are the complications if you give deeply: prostatitis, pelvic sepsis, impotence, and rectovaginal fistula. So these are the complications if you give too deeply. So next is the Barron's banding. See, here you can see the Barron's band. So these techniques usually we are not doing here. They are doing it higher advanced centers. Okay, advanced centers. So this Barron's banding indication is to treat bulky piles. Okay, see here you can see this is the Barron's banding applicator. Okay, here with the inside it they have sent a forceps and they are holding the fundus of this. See, this is the base of the anal base of the hemorrhoid. This is the fundus. They have hold the fundus and they will fire the applicator. When they fire the applicator, what happens? You can see two arrows. So these are the elastic band. Two elastic black bands are there. So when they fire outside, what happens is these two bands will advance. They will advance towards the base. They will advance towards the base of the pedicle, and these bands will tightly snug the base of the pedicle, hemorrhoidal pedicle. Okay, so you can see here rubber bands which have been tightly applied to the base of the pedicle. So what is the mechanism behind this? So when you applied elastic band, what happens to the distal part? So the blood supply will be lost. So what happens? There will be ischemia. When there is ischemia, there will be necrosis. So ischemic necrosis causes sloughing of this hemorrhoid within 10 days. Okay, so patient, after applying this, patient within 10 days you should explain to the patient that so ఇది అప్లై చేసిన తర్వాత కొద్దిగా బ్లీడింగ్ వస్తుందయ్యా, కంగారు పడకు అని చెప్పాలి. ఎందుకంటే because ischemic necrosis వల్ల ఇది slough off అయిపోతుంది. This will get sloughed off and it will present as bleeding. So nothing to worry about that. So again the patient should be reassessed after 8 weeks and you should see whether the hemorrhoids have been well treated or not. If it is not well treated, then also again you may have to apply this band. Okay, so this is the Barron's banding. Okay, that you should remember. Next, coming to the operative management. Operative management, the indications are, see, first is the, if the second degree piles which are not been cured or if have been failed by non-operative methods, that is sclerotherapy, Barron's banding valla fail అయిపోతే second degree piles you have to operate. Definitely third and fourth degree piles should be undergo surgery, and fibrosed piles and internal external piles and hemorrhoids which are associated with bleeding which causing severe anemia. So these are the common indications which you do where you operate a patient. Okay, second degree piles failed with non-operative methods, third degree and fourth degree piles, fibrosed piles, internal external piles, and hemorrhoids which causing bleeding, which causing severe anemia. Okay, so these are the operative techniques. So what we do here is commonly is the open technique. Open technique, that is called Milligan-Morgan's open hemorrhoidectomy. Another is the closed technique. Okay, that is called Ferguson's closed hemorrhoidectomy technique. Third is the stapler hemorrhoidopexy or stapler hemorrhoidopectomy, sorry, hemorrhoidectomy or hemorrhoidopexy, which is devised by Longo stapler hemorrhoidopexy. Next, rarely these are not being done, maybe they may be doing the last two in the maybe in the US or European centers. Transanal hemorrhoidal dearterialization, just you remember these names. No one are doing in our day, in our India. Okay, so mostly the above three procedures are only being done commonly and routinely. Okay, transanal hemorrhoidal dearterialization. Okay, last is hemorrhoidal artery ligation operation, halo, it is called halo. See here in transanal hemorrhoidal dearterization, they do is through transanal they will send an ultrasound, Doppler ultrasound, and under Doppler ultrasound guidance they will do suture mucopexy, that is they will take a needle inside, under Doppler guidance, ultrasound guidance, they will suture it, they will suture the base of the pedicle of the hemorrhoid. That is what they will do. Just you remember the names, the transanal hemorrhoidal dearterialization, halo technique, that is hemorrhoidal artery ligation operation. But the you should remember the first, if anyone asks what are the technique, is open technique, Milligan-Morgan's Ferguson closed technique, and Longo's stapler hemorrhoidopexy or hemorrhoidectomy. So here is the open technique, Milligan-Morgan technique. I am not giving you the total details, just I will explain the procedure. So before any hemorrhoidectomy procedure, patient should be given stool softeners the night before the surgery, number one. Number two is in the early morning at 6 o'clock the patient should be given a soap water enema, so that the patient will pass stools and patient anal canal and rectum will be free of stools. Okay, and the patient will be shifted to operation theater. Patient will be kept in lithotomy position. Patient will be kept in lithotomy position after giving spinal anesthesia. After giving spinal anesthesia, patient is kept in lithotomy position. So when you give lithotomy position, when you put a xylocaine over a gloved finger and you dilate the anal canal first, then you will see anal cushions or the hemorrhoids will be bulging out. So in the first picture A depicts that you will, so 3 o'clock, 7 o'clock, 11 o'clock. So each hemorrhoidal mass you will be holding with the two artery forceps. One inside one will be the coccus. Inside one you will hold the fundus of the hemorrhoid with the coccus arterial forceps, and the skin lying over the hemorrhoidal mass you will hold it with straight artery forces. Like that, these three positions should be held. So when the assistant holds all these three things, it will form a triangle. You can see it will form a triangle. So now what you will do is, you should first, if you do the left side, here is that 3 o'clock position, you just insert a forefinger, insert your index finger into the anal canal, and with your palm you hold this hemorrhoidal mass, and you give a V cut, you give a V-shaped cut. you should give a V-shaped cut over the base, okay, or the skin, and you need to cut the skin and the fibers. So when you cut here, see, if you cut here, you can see the internal sphincteric fibers, plum colored internal sphincteric fibers will be visualized. After cutting it, what you will do is you will transfix. You will transfix means you will take a needle, pass through the base of the pedicle, you will tie it again around it, you will bring it and you will tie it. You will do transfixation and ligation of the base of the pedicle, and redundant part of the hemorrhoidal mass you will excise. Okay, that is the open hemorrhoidectomy. So at all the three position, 3, 7 and 11 o'clock position, you should do the same technique, and you will be leaving open this raw wound. You leaving open this raw wound. This raw wound should be covered with a paraffin gauze, that is QT cell, chlorhexidine gauze piece, paraffin gauze piece. You should close and you apply a T-shaped bandage should be applied. That is the open technique. Okay, and the most important thing here is you should leave skin bridges. See, here 7 o'clock is there, here 11 o'clock is there, here something you have left it, that is the mucocutaneous bridge. So if you remove this part also, what happens, there will be anal stenosis post-operatively. So always you should remember in hemorrhoidectomies, between these pile masses you should leave adequate skin bridges. Mucocutaneous bridges should be left between these excised pile masses. If there is no adequate space between these two piles after removing, so what happens is there will be post-operative stenosis and stricture will happen. Okay, that is the main thing you should remember during operation. So the next is the Ferguson closure technique. So there is no difference, a lot of difference between the open technique and the closure technique. There is a minute difference is there. See, same as the open technique, they have given a V-cut incision. They have excised the hemorrhoidal mass from the underlying internal anal sphincter, and they have transfixation and ligation has been done. But in the closure technique, what they have done is this open, whereas in the open technique we are leaving the raw wound. Okay, mucus and the skin bridge, we are opening the we are leaving this open, we are not closing with sutures, we are just opening. These will heal by secondary intention. These will heal slowly by secondary intention, whereas in closure technique you are suturing the wound and you are closing the wound. Okay, that is the main difference. Rest of the technique is the same thing, but the raw wound is closed with the suture. Okay, in that you are leaving it open to heal with secondary intention. That is the main difference between these two techniques. No other difference. Okay, so next is the stapler hemorrhoidopexy. This, if you see only, you will understand. If you see the procedure only, you will understand, but you just remember, I will try to explain it. So this is the main in stapler hemorrhoidectomy. So what you are doing is, uh, mm, see, I have told you for the see, anal cushions are actually very important, because for a person for the defecation, anal cushions are very important. Those anal cushion contain supporting structures. So in open and closed hemorrhoidectomy, what we are doing is we are removing those bulged anal cushions. We are cutting those anal cushions. But in stapler hemorrhoidectomy, the phenomenon, the main basic mechanism here is you are not removing the anal cushions. Here you are relieving the symptoms. You are relieving the symptoms. You are not removing the anal cushions. So without removing anal cushions, how the patient is getting symptomatically relief? Symptomatic relief is coming. So here what you are doing is you are ligating. You are ligating. You are ligating the vessels above the dentate line. See here. See, first what you do is you put a dilator. First you will put a dilator, and this is the circular dilator, and you will fix it to the overlying buttocks. Okay, then now you will pass a needle here. You will pass a needle inside, and at the base of the pedicle you will take bites, multiple bites in the mucosa and the submucosal plane, all around in circumferentially, all around circumferentially you will take here, and that is called as a purse string suture. That is called the purse string suture. So here this purse string suture is attached to the introducer. Here you can see the bursting suture is attached to the introducer, and now the stapling gun is introduced. The stapling gun is introduced. So within this one, here you can see this is called anvil. Okay, this is called anvil. Between this one and this one, here you can here the tissue will be there. What tissue will be there is the mucosa and the submucosa what you have taken. Okay, the mucosa, submucosa. In the submucosa, the vessels, the superior hemorrhoidal plexus vessels are you have taken. So within that one, you will have the mucosa and submucosa, and you will press it. You will press it and you will fire. Outside, you will fire with the gun. When you fire the gun, what happens? There will be circumferential mucosa and submucosa will come out as a ring. Come out as a ring. Okay, when you remove it, it will come out as a ring. It will be, you will tell it as, they call it as donut, like a donut. If you see, you go to bakery and see a donut, సో వడలా ఉంటది, మధ్యలో కన్నం ఉండి చుట్టూరా ఇది ఉంటది, అట్లాగా డౌనట్ అంటారు. సో దట్ they describe it as a donut. Okay, the donut should contain a mucosa and the submucosa, then only the procedure is complete. Okay, that is the thing they will do. And after cutting the mucosa and submucosa, automatically this stapler will fire the staples all around circumferentially. Here is the staple line. Okay, then it will close it. Okay, so once you have cut the mucosa and the submucosa circumferentially, there will be a raw area. So what happens, that raw area will be stapled by the gun, so it will cut and it will suture also. Suture means with staples. Okay, see here he excising a mucosa donut. You can see here, it is written mucosal donut. So here after the operation you will see a staple line, but here you can see the anal cushions are maintained. Anal cushions are maintained, but the patient will have symptomatic relief if you do correctly. So this is also in vogue. So if you, this should be done in only in experienced surgeons, experienced hands of a surgeon. Okay, not all can do this one. Okay, it is very comfortable to the patient. It is very less painful, less traumatic to the patient. It is a, can be do as a daycare surgery. Morning if he can come morning. If you do, patient can be discharged in the evening or next day morning. It is a daycare surgery. That will, that much comfort will be there. But you should be it should be done in under an experienced surgeon. So what happens if it is not done properly? What happens? There will be recurrence will be there. And if it involves the internal sphincter, if it involves the underlying, if you take the bite of the internal sphincter also come, part of the internal sphincter comes, means patient will have incontinence, and patient may sometimes have a stricture also. Okay, so those are the complications, but this should be done only under a guidance of a trained surgeon, or by, it should be done by a trained surgeon only. But usually we do here in our hospital open technique or a closed technique, Milligan Morgan's or Ferguson technique. Okay, so what are the, this is the last slide, I will complete it. So what are the post-operative complications? So so after a surgery, how do you take care of the patient? So after surgery, you will put him on antibiotics, you will give analgesic for the pain, and you will ask the patient to you will go for hot sidge baths. Sidge bath, that is, you will take a vessel, steel basin or a plastic basin, you will fill it with warm water, and you will ask the patient to sit in that, so that the hot water should touch the post-operative area, that wound. Okay, that will give some soothing effect. Okay, those are the sidge baths. And you will ask the patient to take stool softeners, and you will advise the patient to not to strain while passing stool, and the daily the stool should pass freely. Okay, those, that is the post-operative care and the advice. So what complications may occur during after the operation? So patient, early patient may have pain. Patient will have severe pain will be there, because that area is a fine nerve endings will be there. Patient will have severe pain. For that, the treatment is you give an analgesic. It may be an NSAID, non-steroidal diclofenac, or an tramadol. You give an analgesic, number one. Number two is acute retention of urine. Acute, I have told you, inferior rectal now it will supply the sphincter urethra also at the same time. So patient, due to the pain, he may not pass urine also. That is, acute retention of urine may come, and then you should catheterize the bladder to relieve it. Okay, Number 3 is reactionary hemorrhage. Reactionary hemorrhage is something that bleeding which occurs after 24 hours, 24 to 48 hours, and it occurs due to some disruption of the blood clot. Okay, some disruption of the blood clot, or when the patient from normotensive to patient from hypotensive to normotensive patient will come, because after giving fluids in the first post-operative day, patient volume will be increased and sometimes there may occur bleeding. So whenever there is a bleeding, you should definitely immediately you will shift the patient to the operation theater. Operation theater తీసుకెళ్ళి you have to examine the rectum. If there is any bleeding, you need to underrun the bleeding, that is under the needle. With the needle you will underrun the bleeding point, okay, and you will stop the bleeding, okay, or you can apply a diathermy. That is how you will stop the hemorrhage. But still the hemorrhage has been not been stopped and still there is a oozing. What you will do is you will just put a pack, tight pack you will put into the anal canal, and you will, and with pressure also it will stop, okay. So those are the early complications. So what are the late complication? Late complication is secondary hemorrhage. Secondary hemorrhage is occurring after 48 hours, that is occurring at the 6th day or the 7th day, okay. That secondary hemorrhage is also treated as the same I have told you, okay. You can put a pack and you can stop it, okay. Next is the anal stricture. I told you before previously, if you don't leave adequate mucocutaneous bridges between the excised piles, what happens is there will be anal stricture and anal stenosis, and the patient will not be able to pass motion also. At that time, what you have to do is patient should be again shifted to operation theater, and under general anesthesia, you need to do manual anal dilatation. You need to do anal dilatation. Okay, then the anal canal will stretch. Okay, then anal fissure and submucosal abscesses are the other late complications, and incontinence. So I told you, when you are excising the pile mass, if you inadvertently cut the internal sphincter, you can see that after cutting the excised pile mass, you will see internal sphincteric fibers. Okay, I have shown you internal sphincteric fibers. Here are the internal sphincteric fibers. Here, see, these are the internal. Number 4 represent the internal. If you cut along with the pile mass, if you cut the internal sphincteric fibers, what happens? Patient will have develop incontinence. That one you should avoid. Okay, that you can't do anything. Once cut is cut. Okay, again if you want to do sphincter repair, it is also very a difficult procedure, okay. So that's why you have to do, hemorrhoids is a very important, and the surgery also should be done very carefully. So hope you have understood this topic. So that is the end of this topic. So that finishes our class. So next class we'll discuss some other topic, okay. Thank you.